Good morning, everybody. I hope everybody is having a good July. This is the last grand rounds of July. We have as I often mention, but again, today we have a great grand rounds for you today. We don't have too many updates, but we'll get right into our one main update. And with that being said, I'll turn over to Dr. Dunn.
Good morning, everyone. And I just wanted to announce that you are still able to apply for the LEAD program. The LEAD program is an incredible program calling for applications for mentors who could be faculty or fellows who previously participated in the program, or scholars who are residents and fellows. And the purpose of LEAD is to develop diverse, inclusive leaders who advance health equity. It's a 10-month longitudinal leadership program that provides valuable education in the DEI space for both mentors and scholars. There are monthly 2-hour evening sessions from 6 to 8 p.m. across the 10-month period. And the mentors will help the scholars develop educational workshops on DEI topics, which will be presented at the annual Diversity and Inclusion Forum in May. The deadline for application submission is Sunday, July 30th at 11:59 p.m. Pacific time. So I encourage you all to look a little bit closer at this program and please apply. I'm going to put the link for the application in the chat. It's an amazing program. Back to you, Dr. Olsaga.
Thank you so much, Dr. Dunn. And then briefly, next week, we have since the beginning of the month, August, we'll be kicking off grand rounds with the Chief Scientific Officer, the CSO of Microsoft. He'll be flying down in person to present Dr. Horwitz, to talk about, we don't have the exact title yet, but we've asked him to talk about essentially AI language models, ChatGPT. As you may know, Microsoft is a major stake owner in OpenAI, ChatGPT. So he's going to be talking about the future of language models, AI in medicine. So it should be a really interesting one. Hopefully we'll get some insights. So please do join on Zoom if it's best for you, but if you can join in person, please do come join us in person, get some free breakfast, and hopefully we'll see you there on campus. So let us know if you have any questions about that in advance. And that being said, so that's our updates for today. I'm going to turn over to Dr. David Marin to introduce Dr. Stafford, our speaker today. Dr. Marin, thanks for being here.
Thank you. So Dr. Randy Stafford earned his BA in sociology at Reed College, where his senior thesis focused on health disparities in chronic disease mortality. This was 1980. He was clearly ahead of his time. He earned a graduate degree after that in public health at Johns Hopkins, and he was in his 20s when he developed renal failure and underwent a renal transplant. This was a pivotal life moment that led him to become a physician and clinical researcher with a keen eye on patient-centered outcomes. He entered the joint medical program at UC Berkeley, UCSF, where he received his MD and a PhD in epidemiology. After a postdoctoral fellowship training at the CDC and internal medicine training at MGH, he became a member of the Harvard faculty and stayed there for 7 years. His very first paper was as senior author on the socioeconomic differences in rates of cesarean section in the New England Journal of Medicine. Stanford was fortunate to recruit him in 2001, where he rose through the ranks to become tenured professor at SPRC. At SPRC, his research focuses on chronic disease prevention and treatment. His research has been sponsored by NIH, PCORI, AHRQ, and the American Heart Association. Today, his presentation derives from a project funded by the AHA regarding decision-making around anticoagulation in patients with atrial fibrillation. The title of his presentation is Overcoming Paternalism in Medical Decision-Making, Developing and Testing a Digital Patient Tool for Atrial Fibrillation Stroke Prevention. Dr. Stafford.
So much appreciate your introduction, David. And it's really a pleasure to be here to talk about overcoming paternalism in medical decision-making, developing and testing a digital patient tool for atrial fibrillation stroke prevention. So I have many people to thank, particularly the sponsors of this research, the Joe and Linda Clapety Foundation, as well as the American Heart Association. It also, I want to take a moment to just say that the tools I'm going to talk about are available online. Here are the websites, and here are the smart phrases for Stanford Epic. I have so many people that participated in this project, and it's really been about 5 years in coming. Foremost, I want to thank Paul Wong, who is a co-PI on this project. You can see that we made use of a large number of researchers and research institutions. I'm particularly proud of the inclusion of Melanie True Hills as our patient advocate representative. I have these disclosures about my service as a medical advisor to a couple of startup companies, and want to start out by talking about Mrs. Jones and whether we can do better. So Mrs. Jones is a 79-year-old retired seamstress with hypertension and type 2 diabetes. Her CHA2DS2-VASc score is 5, which equates to a 7% annual stroke risk. Anticoagulation is recommended and prescribed, but unfortunately, Ms. Jones declines to pick up her blood thinner. She says, "I just don't know. I didn't really understand stroke risk, and bleeding risk must be very high." She ends this encounter not very satisfied with the process. And if anything, her distrust in medical care is heightened. So what's the primary problem here? We have a current stroke prevention practices in atrial fibrillation that often are made without meaningful patient involvement. And I would submit that this leads to a lack of patient involvement and engaged commitment. It has therapy mismatched with patient preferences. It wastes healthcare resources, and there are preventable adverse outcomes that occur. So if we think about paternalism in healthcare, and here's a definition of paternalism, I think we can see that there are many reasons why healthcare, by some degree, needs to be paternalistic. There's an interest of preventing patients from making decisions that are contrary to their long-term welfare. We want to prevent the entry of factors that could bias or obscure good decision-making. And of course, we want to allow providers to make use of their technical knowledge to weigh issues that may be difficult to communicate with patients. So in some ways, it's quite valid that parts of healthcare are quite paternalistic. On the other hand, when we think about paternalism, we know offhand that substituted judgment results in care that patients might not choose for themselves. Each patient's evaluation of various outcomes may differ from other patients and from the physicians taking care of them. There are emotional evaluation of therapies and outcomes that are going to happen. And in large part, we make use of this emotional attachment to motivate engagement and adherence to medical strategies. Patients are capable of understanding complex information and trade-offs if presented plainly in terms they understand. I would also say that providers themselves come with their own biases, including a whole raft of explicit and implicit conflicts of interest. And finally, it's important to recognize that there have been past abuses of paternalism that have created significant distrust of our healthcare system. Chronic disease in some ways requires engaged patient participants, and paternalistic decision-making works against this engagement. So our hypothesis for this study is essentially that our novel shared decision-making tool is more effective than usual care based on patient-selected outcomes. Our first step was the development of the tool with a design thinking framework. We used a number of ways of gathering information from patients, and were able to develop a web-based app running on multiple platforms. We use plain language, English and Spanish, in constructing our script. And we essentially focused on two questions. The first, what does the end user need to know to prepare to discuss blood thinners? And how can we best convey what's important? In this endeavor, we were aided by two companies, Daylight Design for design thinking and Blackbird for web services. Our tool starts with a journey and a main video. The website, as I'll mention many times, is afibguide.com. Our main video uses animation and narration with minimal need for reading. We have these cartoon characters and depictions in motion of the function of the heart in normal function and in atrial fibrillation. Our tool provides answers to common questions about atrial fibrillation. And this question section also allows patients to hear other patients' stories. We have a check-in, which in a way is a gentle self-assessment that emphasizes the key messages that are embedded throughout the tool, including why AFib is dangerous. A wrap-up ends the journey. A decision worksheet is used by the clinician and the patient in their discussion. At the same time, we have a clinician guide, which is separate from the patient tool. This clinician guide includes videos and a risk score calculator. Additionally, the clinician tool includes things like a list of blood thinners, a comparison chart of these drugs, information about the Watchman device for a left atrial appendage closure, and video balancing risks and benefits. So once developed and tested and ready for testing, our next step was a randomized clinical trial. We had a 2-arm randomized multi-site comparative effectiveness trial comparing the shared decision-making tool with usual care. We were able to recruit 1,001 patients from 5 clinical sites. And of course, this is registered in clinicaltrials.gov. Our clinical sites were largely in the East and in the South. But of course, we balanced these with a prominent institution on the West Coast. Our inclusion criteria were quite simple: non-valvular atrial fibrillation with a CHA2DS2-VASc score of 1 or greater for men and 2 or greater for women. We required that the participants be English or Spanish speakers. Our exclusion criteria, likewise, were quite simple and really aimed at making sure that a simple rule of thumb for decision-making about blood thinners could apply to all of the participants. Our primary outcome was decisional conflict score at 1 month after the initial visit. The study began with the patient using the tool, followed by a visit with the clinician, where the clinician used the clinician tool to help guide the discussion with the patient. The decisional conflict score was found to be favored in our sub-study of people with atrial fibrillation, which I'll talk about in a moment. A little detail about the DCS. This is a 16-item survey, which is weighted to yield scores between 0 and 100. The higher the value, the more conflict the participant feels about the decision that's been made. To give you an idea of what it entails, it has subscores in these areas. Our outcome sub-study recruited participants matching those of our future RCT. We incorporated the opinions of 100 participants. There was no overlap of these participants with those people who participated in the clinical trial. For this sub-study, we presented participants with surveys for both DCS and the decisional conflict, decisional regret score. And we essentially asked them, which set of questions provides a better assessment of your decision-making experience with blood thinners? In this study, 77 of the 100 patients chose the decisional conflict scale. The other 23 chose the decisional regret scale. There was consistent selection of the DCS across multiple characteristics. The only statistical difference was those people with low CHADS-VAS scores preferred the DCS much more highly than those that had high CHADS-VAS risk scores. You can see that even for the latter group, however, a majority preferred the DCS as the best instrument. So our key secondary endpoints included the decision regret score at 1 month. And here, the higher the score, the more regret the patient feels about the decision that's been made. We also developed the idea of a composite of decisional conflict and decision regret at 1 month. This was weighted according to the 77-23 split in our AFib outcomes sub-study. We also used an outcome developed with the University of Utah measuring AFib knowledge. The higher the score, the more correct knowledge about AFib and blood thinners. I want to take a moment. I feel like there should almost be a moment of silence, just reflecting on the impact that the COVID-19 pandemic had on this study, and of course on many other studies. We initiated our in-person enrollment at Stanford in December of 2019, but quickly ran into some trouble. Recruitment was halted due to COVID-19 in March of 2020. And after this, we worked very steadily to redesign the study and seek IRB review of a hybrid model where we might approach patients fully by video calls or a combination of video calls and in-person engagement. In May 2020, we lost our University of Boston University site due to a major staff and faculty outbreak of COVID-19. We restarted enrollment using remote mode only in May 2020. And in July 2020, we added additional sites, mostly in a hybrid mode, where some patients would engage fully on video, other patients a combination of video and in person. So we consider this a major struggle to get through this. I know that many other studies were halted and some of them recovered, some of them did not. But I feel proud and very pleased by the diligent work of our staff and our PIs at other sites, as well as the attention the IRB at Stanford and at our private IRB gave to the issues involved in redesigning this study. So I want to talk about our results. So our consort diagram looks like this. I'm not going to go over this in detail, but I will say that at 1 month, our primary outcome, we retained 96% of our participants. At 6 months, a secondary outcome, we retained 90% of our participants. And our analysis, of course, was intent to treat. In terms of participant characteristics, you can see here that this is an older population. It's slightly more male than female, despite our best efforts to equalize recruitment of men and women. In terms of race and ethnicity, unfortunately, largely non-Hispanic white, although we did have a fair representation of African-American participants in the study. The participants, many had already started anticoagulation, but about half had been on anticoagulation for less than 6 months at the time of their study visit. The CHA2DS2-VASc score had a mean of 3.4. And of course, this is a population with multiple comorbidities, including diabetes, hypertension, and vascular disease. On all of these characteristics, the two samples were matched well, as befitting the randomization scheme that we had used. So in terms of our study results, our main result is that decisional conflict at 1 month was clinically and statistically significantly decreased in the AFib tool group. As you can see here, usual care had almost twice the decisional conflict scores as the AFib tool, and this was highly statistically significant. In terms of our key secondary endpoints, you can see that decisional regret also was doubled in the usual care group compared to the AFib tool. Our composite outcome, combining these two scales, was even more highly significant. We also measured other key outcomes, including preparation for decision-making, which was better in the AFib tool, and AFib knowledge was higher in those using the AFib tool. Again, these are all assessed at 1 month, our primary time point. We noted that decisional conflict varied across the visits. Immediately post-visit, there was this large difference in the decisional conflict between the usual care in gray and the tool intervention group in red. This difference persisted all the way to 9 months, although it did wane in its magnitude over time. I think it's important to pair these statistical results with the actual lived experiences of patients who participated in the study. So Mr. D was a 51-year-old African-American FedEx driver. He had a history of type 2 diabetes and was diagnosed with AFib 6 months before he participated in the study. He had a relatively low CHA2DS2-VASc score of 2, and with his wife, he used the AFib tool during a video visit. He said, "This tool would have been beneficial earlier for me." And during the clinician visit, the clinician tool was used by the provider to discuss the risks of AFib, the benefits of blood thinners, and to illustrate exactly what happens during a stroke. His AFib knowledge score rose from 63% before the physician visit and his use of the patient tool to 100% afterwards. And his decisional conflict was very low, both immediately after the study visit, as well as at 1 month and at 6 months. Another participant, Miss C, is a 69-year-old white retired teacher. She had a higher CHA2DS2-VASc score of 5, and she said, "It should be made available to all patients because it provided helpful images that improved my understanding." The patient explained that the tool appeared to fill a gap created because most clinicians are so pressed for time, and many patients do not know what to ask about when presented with such decisions. So in summary, our approach had multiple strengths. It focused on patient participation and patient-selected outcomes. We sought to empower vulnerable populations to play a meaningful role in their healthcare. We leveraged innovative tools to do this in a way that did not take extra clinician time. We maximize the collaboration between clinicians and their patients. Furthermore, from the beginning, we engage stakeholders, principally patients, but many other groups, including providers of healthcare, professional organizations, the pharmaceutical industry, the purchasers of healthcare, and many other sectors. And we feel that this study built a strong research and training framework that we are going to use in future studies. Our conclusions are very simple. Compared to usual care, the AFib guide resulted in less decisional conflict. This impact diminished over time, but was still sizable, even 6 months after the study visit. We also reduced decision regret and improved AFib knowledge. It's notable that our study was successful where other strategies have failed. In particular, a study published by the Mayo Clinic. Our study was successful because it emphasized the pre-visit tool, emphasizing educating and empowering the patient before they met with the patient. The Mayo tool really focused on the clinician encounter tool. I believe we also more fully addressed barriers to communication, and our patient-centered design and implementation was quite different. But there's more. So as with any study, it's very important that we fully leverage the results. I think it's important to recognize the amount of funding that went into this study and the enormous effort that all of the investigators and all the staff and all of our participants invested in this study. We want to have the maximal return on that study resources. And we can only do that by focusing on how to successfully facilitate adoption of this tool. So one thing I want to remind you of is this tool is readily available. We have put the website in the public domain following the conclusion of the clinical trial. And we've had broad partnering with key stakeholders, professional organizations, policymakers, consumers, healthcare providers and purchasers, the academic world and industry. We've had several prominent presentations, including simultaneous publication at the American Heart Association annual sessions last year. And we have a study website devoted to explaining the tool to both patients and to providers. We've created electronic brochures and cards in multiple languages with QR codes for easy access. And finally, we've created some epic smart phrases that can allow you as the clinician to send out the AFib guide to appropriate patients and then document this action in your notes. Here is the example of our English version brochure. And as you can see here, we have the smart phrases for Stanford Epic, both sending out the tool in a My Health message, as well as documenting this action within your notes. We have both the patient tool available at this website, as well as using this QR code, and then the clinician tool, likewise available both via QR code and at this website. You hopefully be seeing these cards to remind you to use this tool with your patients with atrial fibrillation. One of the nice things about the intervention is we can actually track how frequently this intervention is being used. We have monitored daily uses of the AFib guide since the middle of last year. And one can see that we started out quite slowly, measuring daily uses on a log scale here. There were two events that I want to point out. One was our presentation of these results in November of last year at the American Heart Association late-breaking presentation. We had simultaneous publication of our work in the Journal of the American Heart Association. And then earlier this year, we had a major spike in use associated with our partnership with stopafib.org. This is a patient advocacy group run by our main patient advocate partner, Melanie True Hills. So where is reduction of paternalism most needed? As in this study, I think what we're seeing is that patients benefit when technically complex healthcare decisions are explained in a manner where they need to understand, what am I getting into? Although anticoagulation is not a one-time decision, it is an important decision. And we feel that patients will benefit from knowing what they're getting into with anticoagulation for stroke prevention. We also see complex healthcare decisions being aided by digital tools where there's equipoise about the most effective decisions and the most effective therapies. In situations where patient preferences are critical decisions, again, this is where we need patients to be involved. Where there's a gap between recommendations and practice, likewise. And where there's a potential for physician bias and conflict of interest, I think it's very important to make sure that patients' voices are being heard. And I can't think of many issues where there isn't at least some potential for physician bias. Finally, when we see healthcare disparities suggesting inconsistent messaging, this is a clue to me that we need more patient involvement. So what's next on our research agenda? Well, Paul Wong and I are already designing a Stanford ICD decision tool to aid patients in thinking about implantable cardioverter defibrillator decisions. As with our AFib tool, we take patients on a journey, in this case, a road trip aided by technology. So that's all I have to say. I'm so willing to answer questions that you have. Please insert your questions in the Q&A, and I look forward to our discussion.
Dr. Stafford, thank you for this great work and for sharing it with us today. It's funny, I had a question I was going to ask you. What's the future of this? It sounds like you created not just a tool for AFib, but you created a tool for decision making and a process of creating that tool specifically for AFib. So you can use
that's exactly right. And in fact, our initial proposal to the American Heart Association for funding really made the case that this is just one example where shared decision making would be very useful, and that many others exist. So as we proceeded with this study, we really had the idea that we were creating a template that could be used for many other clinical situations. And certainly the one of implantable cardioverter defibrillators is a prominent one in healthcare. This is a common procedure in the elderly and is often done in such a way that patients don't necessarily understand fully the downsides and the benefits of ICDs. But I don't think that there are many complex clinical decisions that couldn't benefit from this approach and couldn't benefit from the creation of a digital tool. And as you suggest, our research framework, as well as our framework for developing the tool, are modular and built in such a way that they can easily be adapted to other clinical situations.
Excellent. A couple of questions from Dr. Golden popped up that he was asking towards the beginning of your speech, your thoughts about the Apple Watch and diagnosis of AFib, that you probably get a lot of people who first got the diagnosis that way these days. He's also asking, do you know, I don't know if I pronounced it right, Seysan Feria Bend from UCSF, UCB?
Yeah, so first of all, Susan Feierabend was one of my classmates at the UC San Francisco, UC Berkeley Joint Medical Program. And since the question was asked, I'll just put in a word for the joint medical program. I found it an incredibly helpful process to go through, quite different than other medical schools. And at the age of 28, when I entered that program, I was in the middle of the pack in terms of age. So to answer the first question, I think what we're seeing is the use of other technologies as entryways into healthcare for atrial fibrillation. And one reason our tool is particularly important is that I think we are going to see patients presenting to their primary care doctor or even their cardiologist saying, I think I have atrial fibrillation. So I think the time is right to begin using this tool as part of our clinical care, because I do anticipate that we're going to have an influx of patients with a presumptive diagnosis of atrial fibrillation from their wearables.
Got it. Question, and Dr. Golden's mentioning I think he said he did anatomy with you and you have not aged. Dr. Lafayette.
That's clearly not true.
Dr. Lafayette's mentioning, congrats, clearly getting patients more educated. Have you modeled or measured how this would impact quality of life, adherence to medications, freedom from strokes versus more bleeds?
So we didn't specifically look at those outcomes as part of the study, because with our population, even 1,000 people, we had insufficient power to meaningfully examine those outcomes. However, when we do look at those outcomes, we see no differences, at least in those small numbers, between the AFib tool group and the usual care group. The bigger question is, if we took these results and made some assumptions that our tool would improve both persistence, or actually all three would improve starting anticoagulation, the persistence of anticoagulation, and the adherence to anticoagulation, we could theoretically model what the impact of this type of tool was. The impact would be large, mostly because it's been estimated that roughly 25 to 30% of patients who are eligible for blood thinners are not taking them for a variety of reasons, including the three barriers that I just mentioned. So we have a large number of patients with AFib out there not on anticoagulation. Some of them may very well have legitimate reasons for not being on anticoagulation. And of course, part of our study had as its baseline assumption was that if we can educate and fully empower patients to make this decision, we're willing to live with a patient deciding not to be on anticoagulation. And this is, I think, a radical departure in some ways of our usual medical thinking, our usual paternalistic medical thinking about decisions. So from the start, we knew that if an informed patient made a decision after seeing this material, after reviewing the information with our AFib tool, it would be okay if they decided not to begin anticoagulation. So in some sense, we need to factor that into any estimate about the overall impact of this tool. But I can tell you that given that large number of people not on anticoagulation, that widespread use of our tool would in fact result in more people taking anticoagulation, more people persisting in taking it over the long term, and better adherence.
Great, thank you. I'll just mention Dr. Rush Jamison had a similar question about the incidence of stroke, so I'll presume it's a similar answer. I'll go to next Dr. Marin, who's on video, like to make a comment.
So Randy, this is a great platform for shared decision making. Could you, I have a couple of questions. One is, could you say a little bit more about your primary outcome measure this decisional conflict scale. I don't think very many of us are familiar with it, and it seems like it was unusual. Could you just describe it, and how did you arrive at that as the primary outcome measure?
Yeah, thank you for the question. So our choice of the decisional conflict score was really guided by the idea that our primary outcome had to be related to patient experience and patient satisfaction with the decision-making process. And of course, that's a relatively radical departure from traditional studies which use epidemiologic outcomes such as bleeding, stroke, or the occurrence of side effects from anticoagulation. So from the beginning, we focused on patient-centered outcomes. And the fact is, we were really limited in terms of what was available out there to help us measure how well patients did and what their experience was with decision-making. The two most prominent tools were the decision conflict score and the decision regret score. In some ways, looking at those outcomes, neither were perfect for this study, nor for measuring decision-making in general, but they are both highly validated and in some ways quite useful tools to measure patient experience. Being unable to decide ourselves which was most important, we took the unusual step of actually asking the patient population involved to choose the appropriate outcome for us. So in our sub-study of 100 AFib participants, the group clearly favored the decisional conflict score. And that score has these multiple domains. Suffice it to say, those questions asked, the 16 questions, really get at different types of aspects of how a patient feels after a decision has been made, particularly whether they feel that they've had a chance to have their questions answered, whether they feel conflicted about what decision was made, and how effective they feel this decision-making process was. So this is an unusual primary outcome. In some ways, the very request for proposal headed us in the direction of patient-centered outcomes. But after concluding this study, I am even more enthusiastic that we ought to be using this type of outcome to measure how we provide care. And of course, part of our goal in this study was to think about whether there are other ways of potentially measuring the process of care. And we did use several measures, kind of a cluster of measures around satisfaction. As I presented, those measures consistently favored the AFib tool group. And in fact, beyond the measures I mentioned, we had other measures of satisfaction, both from the point of view of the patient and the clinician, which also statistically favored the AFib tool group. So I am a proponent for using this type of outcome and measuring other types of outcomes in a similar manner to guide how we design care and what sort of conclusions we draw about tools that are meant to improve the process of care.
Great. Thank you very much. Dr. Barrett, any other questions? Or
yeah, I did, if I have the time. So I can think of lots of clinical scenarios where this could be useful. Clinician, patient decision-making dilemmas or situations. In my own area of interest, I think about the decision whether or not to revascularize in patients with stable coronary disease, where a strong argument can be made on either way, and patient preference really should govern the decision. And so I guess my question is about dissemination versus studying. Like, for every question, like for the management of breast cancer, for the stable coronary disease, revascularization, do you think that a clinical trial needs to be done for every clinical decision where there is equipoise, so that we know if it helps? Or should this tool just be disseminated and you plug and play, you put in your variables into the platform?
I think that's a really good question. In some ways, of course, your question is rhetorical, because we can't possibly do clinical trials in every situation where we might desire that. I do think there's a need for more research, particularly given the span of results that we see in different trials. I mentioned the Mayo Clinic trial, which was unsuccessful in really changing the patient-centered outcomes. I think we need several things to make this model work. And there is a way in which this is a bit ahead of its time, perhaps. I would say that we are moving towards incorporating these types of tools into everyday practice, and that process should continue. I'm hoping that studies like this one will push that forward. So I think that's going to happen as we become more concerned about equity in healthcare and the quality of the decisions that patients make about their healthcare. I see the need for selected studies where we do test this rigorously, but I think we can also adopt a pragmatic kind of trial type of framework, which weds rigorous study with observational data as we roll out different types of decision-making tools. I will say that this is going to require differences and changes throughout our healthcare system. It's going to require that clinicians really focus on how they communicate. And currently, medical school and residency programs don't necessarily engage trainees in learning how to communicate well with patients. We need to see more of that. We also need to see clinicians fully engaged with these types of technologies and to recognize that these technologies can be time-saving and quality improving. Our whole system for payment of healthcare needs to change, and I believe that these sort of tools fit very well with the model of accountable care organizations, where the healthcare provider organization is taking some risk for the outcomes of its patient, and therefore feels the need, feels the compulsion to invest in these sort of resources. And of course, this does require thinking about the patient population and how the patient population interacts with the healthcare system. One thing that's notable about the pandemic is that we did have a major shift towards care provided through telehealth, and that this change, this sudden revolution in how healthcare is provided, actually moves us further along towards the use of technology. Some patients were quite uncomfortable with that, although I can say among my older patients, they came to really love this technology and the fact that they could see me, see a internal medicine resident from the comfort of their living room. But a question is the patient population ready, both from a technical skills point of view and from a mindset point of view, to enter into shared decision-making? I truly think that at times we underestimate the ability of patients to take on this information. And certainly through the pandemic and through the study, this study taking place during the pandemic, I think we have good evidence that even this older population was quite capable of interacting electronically with the physicians and with the research coordinators. So I think there are doubts about how this can best be implemented. I think it is going to be implemented for a number of reasons. And I think researchers should be there with their quality improvement buddies to make sure that we rigorously study that implementation and that we ensure that we're targeting the right outcomes when it comes to designing and redesigning healthcare.
Thanks, Dr. Stafford. I have a couple of great questions online from Dr. Georgie and Ash, but before that, I want to turn over to Dr. Harrington. Dr. Harrington, thanks for being here.
Hey, Randy, this has been terrific. I joined a little late, but I've been really enjoying the conversation. I'm going to try to tie together a few of the things that you've been talking about here. You've been talking about implementing things in practice. You've been talking about people actually paying for something. And I want to try to wrap around that beginning at the regulatory process. It's interesting that FDA and CMS are part of the same family, HHS, but they don't ever seem to really be aligned with one another, at least from a cardiovascular drug development perspective. FDA has talked for a long time about PROs as an important part of the approval process, but at least in cardiovascular medicine, they almost never use them. What can we do as a community, research community, to maybe make this whole wraparound process better? I mean, I want to see, let's take AFib, reductions in stroke amongst this group of patients. I want to see tolerable levels of bleeding that are outweighed by a reduction in stroke. But I like what you're talking about, because if people don't want to take drugs, it doesn't matter if you have clinical trials evidence that shows that they work. They're not going to work if you don't take them. So how do we reconcile all of this, the approval process, the payment process, and then the adoption and the practice process?
Well, that's a great question, Bob. And of course, if we had an easy answer, you'd be our healthcare czar for the United States and beyond. I think that these are vexing questions. I think at the heart of it is the recognition that we're going to have to do things differently. Medical care and our healthcare system is a system with mutually reinforcing parts that tend to reinforce staying where we are. There's a lot of inertia to keep doing things the way we have traditionally done them. And paternalism in our decision-making, it's part of that tradition. So I think the first step in answer to your very complex question is to really recognize that we have to do things different, that we're willing to try new things, and that we can't justify continuation of our practices simply because that's the way we've traditionally paid for services. That's the way we've traditionally taught medical students and residents or cardiology fellows about care. And, we need to make new changes in our relationships with patients. And in fact, our expectations of patients that things are going to be different. This is a world where we really need to embrace change. And of course, that's been the mantra of quality improvement for a long time. But I think we see that the healthcare system is approaching a level of crisis where all of us need to think in terms of that idea of change being necessary. From a regulatory point of view, I do find it interesting that the FDA has chosen to regulate certain types of digital communications and not others. And in particular, has really kept its hands off of the electronic health record as a tool that clinicians need to use. I do think that even our evolution of electronic health records at Stanford is very telling. When we first adopted Epic more than a decade ago, it was really nothing more than putting into electronic form paper records. And its main use and its main success, as far as I could tell in those early years, was improving our revenue collection. It's really been taking a while to really get EPIC to the point where it's useful for clinicians and patients in the process of improving care. So I think that your question is a really good one. I think that one of the things that needs to change is just the sense that electronic health records are ruling our lives. And I think clinicians do need a bigger role in designing the workflow and the mechanics of electronic health records. From a regulatory viewpoint, I think it's very important that counseling, such as that provided by the tool, be recognized as a valuable service. And I'll use the example of another issue that is a hot topic, which is the use of aspirin for primary and secondary prevention. You know, as we know, aspirin went from having very good evidence of a primary prevention benefit to a point where we are largely giving up aspirin for primary prevention, except perhaps in the most risky patients who have not had a cardiac or cerebrovascular event. For the decision-making process, it's important that physicians take the time to describe the benefits of aspirin and the downsides of aspirin, particularly emphasizing for the secondary prevention population that aspirin is still a mandatory therapy, or at least aspirin or one of its cousins is a mandatory therapy. This takes me to describe a process I went through a decade ago, which was petitioning the Centers for Medicare and Medicaid Services to recognize aspirin counseling as a billable service. And we essentially created an argument and an evidence base for CMS, in the end, approving a process of cardiovascular disease counseling that was separate from their E and M coding. Now, I can tell you that this aspirin and cardiovascular disease counseling service is not frequently billed, but it does create a message that this is an important counseling activity that clinicians can get paid for doing. So I think we're going to need to look at those types of hybrid models as our care shifts towards a more risk-based accountable care organization model. But how we do that is really going to require the thinking of new leaders in this area. And through our project, we've had a number of academic fellows who have really been immersed in the process of patient-centered outcomes. And I'm looking at them to guide us as we figure out exactly how to accomplish what you're suggesting.
Dr. Stafford, thanks for that. We're getting close towards the end, perhaps, but I had a couple of questions I really want to get to. Perhaps we can rapid fire a couple of answers before we hit the end here. Dr. Ash touched on something I wanted I was thinking about the whole time, but he words it so better than I could about the practicality of using this and its implications for other things. He says such important work, particularly its consciousness of how to integrate into practice. Curious as to how you have studied the barriers and facilitators to dissemination formally, perhaps using implementation science frameworks. Could this help with future tools?
Yeah, so from the very beginning in our design of the tool, we had really two mantras. One is keep things simple and understandable. And the other was put this in front of patients, atrial fibrillation patients, to let them tell us what they want to know and how they want information presented. So as we developed this study, we not only sought that sort of input, but we also tested this in real world settings where we could get the input from clinicians And of course, the research investigators were part of this, but we also sought input from community physicians, particularly community electrophysiologists in terms of what they encounter in their daily practice. So the issues of how to make this work in real world settings was a focus from the beginning. We used the REACH framework to think through how we could make this an effective tool that was able to reach the most people, able to accommodate, in particular, those people with low literacy level. And for this reason, we use this almost comic cartoon style of video. And we also really made it possible for people who did not have reading skills to make it through this process and understand more about what they were getting into. I think we need more attention to focusing on good communication. And of course, communication is one of these things where we all think we know how to do it well, but in fact, many of us are only mediocre at being able to communicate information to our patients. We do much better at communicating with colleagues, but we need to learn how to communicate with our patients.
Dr. Stafford, thank you so much. I want to send a special thank you to all of our attendees who stuck with us past 9, all our panelists, Dr. Marin, Dr. Harrington for being on video, and Dr. Stafford, thank you for this excellent work. We'd love to hear how it goes down the line as well, or with ICD or the future implementations of it as well. Good luck with that research. Thank you for being with us today. We'll see you all next week in person for our next grand rounds. And thanks, everybody. Have a great rest of the week.
Thank you all. Appreciate the questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.